All right. Well, hello. Good afternoon to those that are here watching live with us, and hello for those that will be watching in the future to this presentation. So I'm Corey Barat. I am a practicing colorectal surgeon. I am located in Cincinnati, Ohio. I've been with Osler for about 10 years or so. And I've been the course director for the colorectal section for I think 6 or 7 or so. Really when we started this. As you guys probably know, for some of you that have done Osler for general surgery, Osler's been doing general surgery for I don't know, 20 years or so. And I went through the Osler course and then started teaching in the general surgery portion even while I was a fellow in colorectal. And then we had the idea of starting a colorectal division just because of the desire to have training similar to what we do for general surgery. So it's a little bit different format just because it's a lot more condensed. And really, I think part of it also speaks to the level of preparedness of colorectal fellows and those in practice versus those that are in general surgery who have to learn about things that they may not care about or may not need to do anything about in their future career. Whereas for us, it's all sort of important and all can be applied to our daily practice. So anyway, this is going to be a fairly quick clip, quick pace here, just because there's a lot to go through, as you guys can imagine, trying to go through the entirety of colorectal in one day. I do want to say thank you so much to our other colorectal faculty, Dr. Bullar, who's been, I think, part of the Osler as long as I have as well, and Dr. King, who started up when we started doing the colorectal, and Dr. Ferreira, and I think been doing about 4 or 5 years with us as well. So those guys are fantastic. You'll see similar faculty when you do the oral boards as well, and some others that have been fantastic, and of course the Osler staff. So the way we're going to do the format is, it's going to be a lot of presentation, mostly me talking. Feel free to put things in the chat as they come up. I may or may not get to them while we're presenting, or we may save them for the end of the hour, or even potentially the end of the day. We do have a Q&A section blocked off just for things that maybe have come up either during my talks or during the other talks. And it's going to be a bit of an open forum. I mean, I may not have the exact answer to everything. And I think that's something to keep in mind. I mean, we're all practicing colorectal surgeons, but none of us is an island, right? So we all use other resources around us. So, you may see something on one of our slides and say, you know what, I did something a little bit different in my practice, or, hey, I just read an article that's a little bit different, or, so don't, this is not the gospel. This is just a way to try to condense everything that you've learned and remind you to help you guide your studies and hopefully review a lot of the common topics that will be tested on the exam. All right, so let's get started. So we're going to do anatomy, physiology, and benign anorectal version 1. And then, of course, we have version 2. And then we will do pelvic floor as well as ulcerative colitis, IPAA complications. Great stuff for written and oral exam, and then the Q&A. So we'll do anorectal 1 and 2, and then we'll take a break, and then we'll finish out with the rest of the afternoon. So thank you again, and let's get started. All right. So the purpose of this course, as you guys have already experienced, is to highlight the areas of deficiency, solidify concepts you've already learned, review for the written boards, of course. This is, again, not meant to replace a textbook, is not meant to replace clinical judgment and experience, and is not meant to be the only right answer in a given situation. So keep that in mind. Some preliminary stuff about the test itself. I found it to be a very similar style to the ABSITE general surgery style questions, but of course a deeper level of understanding. There's more quote unquote colorectal specific topics like pelvic floor, constipation, rectal cancer, anal cancer, miscellaneous tumors. There may be some slides, pictures, radiology on the test. There's very likely to be more than one correct answer, so you have to pick the most correct. There may be some fairly recent topics, which is, I think, a bit different from general surgery, where they may be a few years behind. For an example, knowing the latest NCCN guidelines for rectal anal cancer is going to be important. There's always going to be a small percentage of testing the test questions, so essentially experimental questions that they will analyze statistically and determine if they want to keep them for next year or whatnot. So you guys have been doing tests your whole life. This is nothing, there's nothing too special. Common sense test taking goes a long way. So again, the format of these lectures, 45 minutes, multiple more or less related topics, some review questions, large breadth of topics covered. And again, some of these we'll try to stick to the schedule, but some of these topics take longer than others. I think most importantly, as a course director and really as instructors and even as just colorectal surgeons, in this relatively small community, we're all in this together, right? We want to make this the best course because we want you guys to feel prepared for your tests. So please send us your feedback. We strive to make this course better. You should be getting a feedback evaluation feedback form, both for CME purposes if you're eligible for that, and really just to make this course better. So honestly, from the bottom of my heart, please reach out if there's anything that comes up or topics you felt need to be covered better, or clarification questions, things like that. All right, so let's get started here. Like I said, some of the stuff is pretty basic. We may kind of skip through relatively quickly. Histology and physiology, some of the key concepts. The colon is innervated by extrinsic and intrinsic systems. Parasympathetic are the excitatory and sympathetic are the inhibitory, as well as the intrinsic system, which is the myenteric plexus. SCFA or short chain fatty acids are produced by the colon as reduced fermentation by carbohydrates by the colonic flora. Butyrate is the most common one that may come up on a test and is a primary energy source. Clinically, this comes up as diversion colitis. If you have a patient that's been diverted, you can see essentially inflammatory changes, erythema, stippling, and bleeding on contact, which is can be diversion colitis due to the lack of essentially nutrients from the stool itself. The colon absorbs sodium, water, and secretes bicarbonate and potassium. Two types of contractions, segmental and propagated. And you have the high amplitude propagating contractions that propel stool distally. You have the interstitial cells of Cajal, which are the primary pacemaker cells governing the enteric nervous system. Here you have your standard 4 layers of the colonic wall, colon histology here. It's good to get a sense of what the normal colon looks like because you may be presented with an abnormal slide and need to recognize what is what. So 3 main epithelial cell types are surface layer cells, columnar, goblet, and enterochromaffin cells. The columnar and goblet make up the majority of the epithelium. The crypt epithelium is highly proliferative, secretes chloride, as we know. The surface epithelium has low proliferation, is well differentiated, and highly absorptive. All right. Cells of the enteric nervous system are in the submucosa, also known as Meissner's plexus. There's an additional layer of nervous cells layer between the intercircular and outer longitudinal layer, also known as Auerbach's plexus. Again, the interstitial cells of Cajal. So this comes into contacts clinically with the c-KIT positive, also known as CD117, with the GI stroma or the GIST tumors that I think have been covered earlier in the day. Okay, good. So questions here. And so now you guys can feel free to put things in the chat. Other than the physiologic function of the interstitial cells of Cajal, why are they clinically significant? I sort of already gave this one away, but I guess a good review, I lobbed this one up for you guys here. So please feel free to participate. So I know that you're awake. All right. A couple people like C. Good. Yep, that is correct. So yeah, in any test taking situation, it's also good to look at the other choices. And if you don't immediately know which things are obvious mistakes or obvious wrong choices, so we know that they are not squamous cell cancers of the anus, precursor cells for adenocarcinoma. We know that's a different cell line. Cajal was a Nobel laureate, so that's a true statement, but that doesn't answer the question of why they're clinically significant. So again, don't jump to something that you know is true if it doesn't necessarily answer the exact question.